Presentation by Dr. Krishnendu Nandi. Dr. Nandi will be presenting on this high myopes, the macular schisis with subretinal fluid, the tips and tricks in managing these patients surgically.
Yeah, thank you, and thank you for the opportunity by Shudipto for giving me the talk on myopic traction maculopathy. This is a myopic maculopathy means big eye, big problem with us. So there are a lot of pathogenesis regarding that on foveal tractional maculopathy. So pathogenesis may be due to the contraction of the posterior hyaloid, or the epithelial membrane formation is the cause of tractional maculopathy, or it may be the retinal vascular traction, the small retinal vessel cause traction and give rise to schisis formation. Rigidity of ILM is another point, and posterior staphyloma is another point, what leads to development of foveal schisis traction maculopathy. So it can lead to foveal schisis, lamellar macular hole formation, full thickness macular hole formation, subretinal fluid formation, or retinal detachment complete. So there are a lot of classification upon the classification of myopic traction maculopathy. This is the classification proposed by Barbara Parolini et al. In 2020. So we have treatment for few cases of traction maculopathy. Sometimes it resolves by its own. It can natural recovery, or we have treatment as vitrectomy with ILM peeling. Macular buckling is another option, and suprachoroidal buckling is another option. So what is the indication of surgery in these cases? Mainly the foveal detachment. Full thickness macular is the second point. Third point is macular hole along with the retinal detachment, and sometimes if the foveal schisis is progressing with a gradual loss of vision. So difficulty which is often faced is the long elongated axial length, which is the main difficult part of the doing surgery, and we cannot reach sometimes to the posterior pole. We have to make some adjustment in order to reach the posterior pole. Now ILM peeling in these cases are very tricky because they are very thin, sticky, cannot come out by its own. We sometimes can come out piece by piece. So what is the difference between idiopathic macular hole and myopic macular hole? The conventional surgery in idiopathic macular hole closure rate is very high, around 90 to 100%. But myopic macular hole closure rate is very low, 60 to 90%. So we may have to modify our surgery, not doing a regular peeling, but go ahead with the inverted peeling sometimes. So surgical tips: we have to keep your port wide apart, not to the superior, at around 9 o'clock, 3 o'clock position. Multiple staining is required in order to see the vitreous properly and do proper PVD induction. BBG dye has to be given multiple times in order to stain the LM because of lack of contrast from the myopic retina. Foveal sparing ILM peeling is required in cases of only foveal schisis without any macular hole. ILM flap is a better choice than the conventional ILM peeling in macular hole surgeries, and wide dissection of ILM required at least to the area of the posterior staphyloma. A gas tamponade gives better result. Why? Because it will cover the posterior staphyloma properly rather than the oil. So inverted ILM peeling plays a significant role in this kind of cases where the posterior staphyloma is there, and very difficult to close this kind of macular hole in a normal conventional peeling technique. Sometimes in spite of doing inverted ILM peeling, we have to use the viscoelastic perfluorocarbon in order to make it stay till the FG is done. So if you can see the study, you can see the myopic macular hole only flap technique and peeling, the flap technique and peeling technique, there is a lot of difference in outcome. So it suggests that if you want to do peeling in cases of macular hole with RD or without RD in myopic patient, inverted flap technique gives a better result. So other techniques also has been described, like many things like a dustbin. You can do whatever you want to peel and peel it and plug it in the dustbin of macular hole. It should not be done. Actually, flap is better method. So anterior posterior segment capsular flap can be used. Autologous transplantation of ILM is also described. Thrombin is also described, the autologous blood, autologous neurosensory retinal flap, amniotic membrane graft. Lot of things have been tried in order to close the myopic macular hole. So coming to macular hole related retinal detachment is a different ball game altogether. You have to induce the PVD. PVD induction is difficult. ILM peeling becomes difficult in these kind of cases. So it's a case of counting finger 3-meter vision with a foveal detachment with a macular hole. So the peripheral retina is attached. You can see the demarcated area of detachment with a central macular hole. We proceed with the surgery. After doing core vitrectomy, we need to stain the vitreous with the triamcinolone acetonide. So triamcinolone acetonide, see, I am peeling with the helping of the soft tip in order to create a plane in the posterior highlight in order to make a complete induction of PVD. So gradually I have succeeded to induce the PVD as it is very sticky adherent to the retina, and using the soft tip cannula to induce the PVD. You can use the forceps also, whatever you are comfortable with. So after inducing PVD is a routine case. Then using FG and then putting the dye. Why I have used FG? Because to make a greater staining of ILM rather than putting a BFG under only saline. So I have started ILM peeling. It's a conventional technique, not the ILM flap. So I need to peel the ILM up to the edge of the subretinal fluid which is there in the posterior pole. So my aim is to peel as much as possible, as I am not doing the inverted flap technique. So I am proceeded with the peeling as much as possible up to the edge of the subretinal fluid at the posterior pole. So after adequate peeling, I'll do FG and put gas. So this is the outcome after 6 weeks. Vision has improved, but you can notice there is a very thin fovea. So we do not expect much better outcome in this kind of cases. So other things also described like posterior buckle, macular buckle. So I don't have any personal experience of that, but it has lot of complication. It has a steep learning curve also. In order to settle, this kind of macular buckle can be used in a very deep-seated eye, very long eye, where posterior staphyloma is quite large, where your instrument, you think your instrument cannot reach up to the posterior pole. So this is a sample which has been published by Dr. Pradeep. There is a macular hole detachment in the posterior pole with a subretinal fluid, both cases, and it has been quite tackled well enough with a macular buckle. So to conclude, is a very difficult scenario for the any beard surgeon. Invert flap, if you are going inside, inverse flap gives you better result. If the axial length is more than 30, deep-seated posterior pole, posterior staphyloma, it gives you a better poor prognostic outcome. Even if you close the hole or settle the retina, visual outcome is very bad. Thank you.
Thank you, Dr. Nandi. I think one very difficult situation sometimes happens when you have a very long axial length and to drain that subretinal fluid. So, Dr. Nandi, you want to comment on this?
Yeah, very difficult to reach at the posterior pole. Sometimes the soft tip cannula gives you extra length, where with which you can draw the fluid, or sometimes you need to take out the cannula, the trocar cannula itself, in order to give you some extra length to introduce the forceps or flute, whichever you have. So that is the technique you can modify with you.
Yeah, that was what I was going to ask you. What are the tips for
either you use soft tip cannula or you take out the trocar and use your instrument through the sclera itself.
Right, and sometimes even after that you will find that you will not you are not able to take that last bit of water out.
Yes.
Last bit of fluid out. Yes. Now sometimes what I have tried is I have tried to change my hands and from my right hand to I have tried to go through the left hand, and sometimes it is possible to enter from the other way around.
So that actually, if you access to the with the eye with the hand where you actually access the
Yes.
macular closure.
Yes, yes,
So I
yes.
think that's
So if
one
you
point.
change the hand and then you take the trocar out and you go straight away without the trocar, I mean cannula, then you purchase that extra amount of
Yes.
length that he was referring to.
Do phobia sparing.
Yes, definitely. In ILM peeling with macular, only subretinal fluid with macular schisis, foveal schisis, I do prefer to do foveal sparing ILM peeling, because otherwise you will reduce and you will iatrogenic cause the macular hole formation later on. Even if you have done foveal sparing, the patient can still end up having macular hole in future.
Right.
So that can be counsel to the patient that you
with
need constant follow-up.
pre-oppositives.
Yeah.
Thank you so much, and thank you so much, audience, for